At this time, we are going to demonstrate a surgical cricothyroidotomy in an adult patient. This is a two-handed procedure. If you are a right-handed surgeon, you should stand on the right side of the patient. If you are a left-handed surgeon, you should stand on the left side of the patient. I am going to demonstrate a surgical cricothyroidotomy for a right-handed surgeon. So as we stand to the right side of the patient, I'm going to use my left hand to stabilize the airway and also help me to identify anatomy. So as a review, when we're feeling the anatomy on the neck, it's easy to start at the bottom and feel the sternal notch. Then when you go up from the sternal notch, you're going to feel a soft structure, which is the trachea. Then you're going to feel your first hard structure, which is the cricoid cartilage. Then there's a divot. Then there's the thyroid cartilage. So between the cricoid cartilage and the thyroid cartilage is the cricothyroid membrane. And that is your surgical airway site. It has a nice scaffolding of the two cartilages above and below. So once again, easiest to feel from the bottom and quickly feel up, hit something hard, then a divot, hit something hard, and you are working between the two hard structures. So I'm going to use my left hand to stabilize that airway. Now as a review, we're going to open the skin here and look at the model, and what you can see is what we've demonstrated. We're working down here at the sternal notch. Here's the trachea. This is the first hard thing, which is our cricoid cartilage, then the divot over the cricothyroid membrane, and then the next hard thing, which is the thyroid cartilage. So as we work our way up, our finger hits something hard, a divot, hard, and we're going to stabilize that with our left hand, since I am a right-handed surgeon, and then I'm going to work over the cricothyroid membrane. When we're using our knife to do the procedure, we're going to cut away from ourselves so we don't hurt ourselves. You can use an 11 blade, you can use a 15 blade. You can use any blade that you need. This is an emergency procedure. You should cut away from yourself. You do not want to cut toward yourself and slide into your hand. So the first cut is going to be over the cricothyroid membrane that we have identified. And we make a large cut. This is not a time for a small cut. This is a life-saving procedure. So you're going to cut through the skin and you're going to continue to cut down until you can feel that you've cut all the way down. So it's a motion of going back and forth. Cut, stick your finger in, feel, cut, until you feel that you're at the cricothyroid membrane. Then you're going to turn your knife and you're going to cut horizontally into the cricothyroid membrane. And this is almost a controlled stabbing technique. You need to puncture the membrane, and then you're going to cut across horizontally. You will know that you are in because you will see air release, and you'll hear air release, and the way that you usually see it is, because it is bloody, you'll usually see air pass by some blood that comes up. So that's a quick internal demonstration of a large sequential cuts, feeling back and forth. I would not recommend sticking your finger in the knife at the same time in the hole. That is dangerous to you as the surgeon. Once you feel that you're all the way down, you turn the knife and you're going to cut horizontally. So here we're going to close the skin. I'm going to approach the patient and I'm going to feel my anatomy. I'm stabilizing with my left hand. I feel the sternal notch. I slide up. Hard thing, gap, hard thing. This is my area. I stabilize with my left hand. I grab my knife in my right hand. I'm going to cut away from myself with a large cut over the cricothyroid membrane. And I can feel, and I stick the knife in, and I'm cutting, and we're doing this with minimal instruments. You don't want to have to learn how to do this with a kit. You want to be able to do this with anything. So I'm continuing to cut through the layers, staying in the midline, until I feel the cricothyroid membrane. Then I'm going to stick my knife inside, and I'm going to turn it horizontally, and I'm going to puncture the cricothyroid membrane, and I'm going to cut across. At this point, I can stick my finger in and feel my finger is in the airway. I can dilate with my finger, or I can dilate with a clamp and stick that in and dilate. What you do not want to do is dilate with the back of your knife handle. If you turn your knife handle around and dilate with the knife handle, you are at risk of cutting yourself. Please do not do that. So you can either dilate with a finger, with your pinky finger, with any finger you have, or if you have a clamp available, you could stick a clamp in and dilate. And I could feel the airway is open, and at this point, I can insert my ET tube, which should be a 6 millimeter ET tube or less. And what we're going to do is we're going to feel our anatomy and we're going to guide the ET tube into the hole. And once the cuff is just inside, we stop because we do not want to right mainstem the patient. Then we can use our syringe to inflate the cuff, and then we maintain our grip on this in order to secure this in whatever way we want to. But I would recommend, even if you secure the ET tube, I would still hold on to it. Then you can attach this ET tube to a BVM or to a ventilator, and you have now gotten your emergency airway. As another option, you can also use a bougie catheter. So I'm going to deflate this and just show you another optional technique here. I'm going to take this ET tube out. So at this point, I have already punctured the cricothyroid membrane. I feel that it's open. I use a bougie catheter to slide in, and I slide it and I can feel it going along the trachea. Then I'm going to take my ET tube and I'm going to slide it over the bougie catheter and slide it into the airway. Once the cuff is in, I can remove the bougie just like before, and I can inflate the cuff, and then we can attach our ET tube to a BVM or to a ventilator in order to oxygenate and ventilate the patient, and I'm going to hold this in place. This is our surgical airway. The last demonstration I want to show is just what it looks like without the skin on it. So I'm going to take this tube out. We're going to open the skin again. I've already made my cuts. You can see that the cut has been through every layer. So we're staying in the midline, so the skin, and then all of the layers in the midline of the neck until we get down to the airway. You can see my horizontal incision in the cricothyroid membrane, and I'm able to stick my finger inside to dilate, or I could stick a clamp inside to dilate. Once I've dilated and verified my anatomy, the ET tube goes into the opening, and once the cuff is just inside, we inflate the cuff, and we attach our ET tube to a BVM or to a ventilator. And at this point, we've secured our airway. We hold the airway in place. We secure it with different techniques, but once again, recommending always to hold it with your hand. And then we move on to the next steps, which is going to be getting a more definitive airway, which could possibly include doing a formal tracheostomy in the operating room.